Good morning, students. Today we will see the remaining part of pain physiology. So in this class we will see the analgesia system, descending pain modulating mechanisms, and the gate control theory, and the pain management and applied aspects of pain. Modulation of pain occurs at three sites: peripherally in the spinal cord and supraspinal. So peripherally is at the nociceptors. So nociceptors are present, otherwise called free nerve endings, which are present in the skin, superficial layers of the skin. And the spinal cord is, we all know, the ascending sensory tracts. They travel through the spinal cord. So at the spinal cord level, the modulation of pain can take place, and above the level of spinal cord, that is the structures which are present above the spinal cord. So what are the structures present above the spinal cord? Brainstem and nervous central cerebral cortex. So the supraspinal structures. So at these three levels, modulation of pain can take place. So modulation means it can the pain sensation can be modified, that is it can be increased or decreased. So this modulation can either inhibit or facilitate the pain. The major site of modulation is dorsal horn of spinal cord. Endogenous analgesic mechanisms. So this is the pain decreasing mechanisms which are present inside the body. Endo means inside. Endogenous. So normally inside the body we have the pain reducing mechanisms. So without taking any medicines, any treatment, our body, nature has designed our body to automatically reduce the pain mechanisms in the human body. So the endogenous analgesic mechanism comprises of endogenously synthesized opioid peptides, which are morphine-like substances. So these opioid peptides are the natural substances which help in reducing the pain. These are found at three different points of the brain, which are broken down products of three large protein molecules. Okay, so the opioid substances found at different points of the brain, which are the broken products of three large protein molecules. So the large protein molecules are pro-opiomelanocortin, which gives the beta endorphin, and pro-enkephalin gives met and lev enkephalins, and pro-dynorphins gives the dynorphins. So these are the opioid substances present at three different points of brain, and which are obtained from the large protein molecules, that is pro-opiomelanocortin, pro-enkephalin and pro-dynorphins. So these are found in the peripheral processes of primary afferent neurons, human synovium and many regions of CNS. Okay, so these opioid substances are founded mainly at the primary afferent neurons and human synovium and many regions of CNS. So in this picture, if you observe, when there is injury, the primary afferent neurons are going into the spinal cord. So the second order neurons will start from there, and then they cross to the opposite side. They go along the spinal cord into the brainstem and the thalamus, and finally here the thalamus, and from here again they go to somatosensory cortex. So this is the ascending pathway. So ascending pathway for pain. So while it is going from the brainstem or from the hypothalamus area, so the another pathways descend. Okay, so these are the descending pain pathways or descending analgesic mechanisms. So there is secretion of endogenous opioids. So this blue colored one, pain inhibition via the endogenous opioid system. So this is one mechanism, and one more mechanism is descending pain inhibition by noradrenaline. So this is a neurotransmitter release, noradrenaline, that also has a role in inhibiting pain. Inhibiting nerve signals are conducted to the synapse in the spinal cord. There noradrenaline is secreted as an inhibitory chemical messenger. So if we see the brain opiate system, we have morphine receptors in the brain and morphine-like neurotransmitters in the brain. Morphine is a potent endogenous analgesic peptide. It acts at synapses of the nociceptive pathways by binding to specific sites, the opiate receptors. So synapses of nociceptive pathway means in the pain pathway we have synapses from first order to second order. So in the spinal cord at that synapse level it acts by binding to the specific site of opiate receptors. So this binding decreases the nociceptive or the pain synaptic excitability. Okay, so that's how the pain pathway is inhibited by the morphine like substances, morphine like neurotransmitters. So they bind to the opioid receptors which are present on the primary efferent neurons. So the three major protein molecules are the large protein molecules are pro-opiomelanocortin, pro-enkephalin, pro-dynorphin, and the substances from these are beta-endorphin, met-and-glue-enkephalin, and dynorphin. So these are particularly present in the spinal cord and the periaqueductal gray matter of midbrain and raphe nucleus in the medulla. These produce an analgesia when they are secreted from different parts of the brain in response to different stimuli. So in the first slide we have seen that there are three levels of modulation, that is peripheral level, spinal cord, and then supraspinal. So one by one we will see. Peripheral modulation, nociceptors and the neurons display sensitization following repeated stimulation. So the free nerve endings and the nerve connections, the neurons passing along with the free nerve endings, they display or they have the property of sensitization following repeated stimulation. So sensitization means the increased sensitivity. It occurs by two mechanisms. Primary hyperalgesia, that is exaggerated response to pain at the site of injury, and secondary hyperalgesia, response to pain outside the site of injury. So these two mechanisms of hyperalgesia can take place by modulating peripherally at the nociceptors level. In primary hyperalgesia, sensitization of nociceptors commonly occurs with injury and following application of heat. So the triggering point for the primary hyperalgesia is injury and following application of heat. It is mediated by the release of halogens from damaged tissues. So what are released? Bradykinins, histamine, serotonin, and prostaglandins. So histamine from platelets and mast cells, bradykinin from macrophages, and serotonin and prostaglandins are also released in primary hyperalgesia. The prostaglandins are produced following tissue damage by the action of phospholipase A2 on phospholipids released from the cell membranes to form arachidonic acid. So the prostaglandins, so we will see out of all those histamine, serotonin, bradykinin and prostaglandin, the main thing is the prostaglandin. So we are going to see about the prostaglandins. So when they are produced following the tissue damage by the action of phospholipase A2 on phospholipids. So the phospholipids from the cell are present in the cell membrane. From that, by the action of phospholipase A2, prostaglandins are produced and they form the arachidonic acid. The cyclooxygenase pathway then converts the latter, that is arachidonic acid, into endoperoxides, okay, which in turn are transformed into prostacyclin and prostaglandin E2. So first from the prostaglandin, arachidonic acid is produced and this will be converted to endoperoxides by cyclooxygenase pathway, which in turn get transformed into prostacyclin and prostaglandin E2. So this PGE2 directly activates the free nerve endings, whereas prostacyclin potentiates the edema from bradykinin. So it acts along with bradykinin to increase the edema. Pharmacological agents such as acetyl salicylic acid or aspirin and acetaminophen and non-steroidal anti-inflammatory drugs NSAIDs produce analgesia by inhibition of COX, that is cyclooxygenase. So these are the drugs which help in reducing the pain. So how they act? They act by inhibiting the cyclooxygenase so that the effects of prostaglandins can be decreased. The analgesic effects of corticosteroids are likely the result of inhibition of prostaglandin production through blockade of phospholipase A2 activation. So corticosteroids, the steroid drugs also have this action, that is inhibition of prostaglandin production, so that they will also help in reduction of pain sensation. In secondary hyperalgesia, which is otherwise called neurogenic inflammation, so the nerves are involved. Inflammation is after an injury, the surrounding tissues will get inflamed. So it is manifested by triple response of a red flush at the site of injury. So whenever there is a pinprick or any scratch like thing has taken place with a sharp object, so we will observe the redness and swelling and pain sensation are present. No? So those three things are called triple response. So that redness is called flare, and local tissue edema will be present, and sensitization to noxious stimuli are present. So this secondary hyperalgesia is due to release of substance P from the collateral axons of primary afferent neurons. So the afferent neurons are present, no, from their collateral axons. So branches will be present. From that collateral axons, the substance P is released, and which is responsible for the secondary hyperalgesia. So what is this substance P? It is a peptide that is synthesized and released by the first order neurons or primary afferent neurons, both peripherally and in the dorsal horn. It degranulates histamine and serotonin, vasodilates the blood vessels, causes tissue edema, and induces the formation of leukotrienes. So these are the actions of substance P. It degranulates the histamine and serotonin and vasodilates the blood vessels, causes tissue edema, and induces the formation of leukotrienes. The compound capsaicin degranulates and depletes substance P. When applied topically, capsaicin diminishes neurogenic inflammation and appears to be useful for some patients with post-therapeutic neuralgia. So this capsaicin compounds degranulates and depletes. So it inhibits the substance P. So when this is applied topically, it helps for some patients, so not all patients. Tissue injury causes release of chemicals. So this is the lesion, site of injury. The chemicals are released, they sensitize or activate the receptors, and neurons release substance P. So these neurons release, the collateral axons will release substance P, which stimulates mast cells and blood vessels, and histamine released from mast cells and bradykinin released from blood vessels add to the painful stimulus. So if this is adding to the painful stimulus, so if we reduce this or inhibit this substance P, automatically there will be some reduction in pain sensation. So till now we have seen the peripheral modulation, and now we will see the central modulation in that facilitation. Three mechanisms are responsible for central sensitization in the spinal cord. One is wind up and sensitization of second order neurons. Wide dynamic range neurons increase their frequency of discharge with same repeated stimuli and exhibit prolonged discharge even after afferent C fiber input has stopped. Okay, so these are the neurons, type of neurons which are present in the spinal cord. In the previous class I have told you. So they increase their frequency of discharge with same repeated stimuli. So the frequency of discharge is increased, so they exhibit a prolonged discharge even after the afferent input has stopped. So this is one mechanism for increased sensitization. And receptor field expansion, that is the dorsal horn neurons increase their receptive field. So the receptive field is a sensory unit, and receptive field in the previous class I have explained you. So the neuron and its area, the supplying area, will be called receptive field. So the dorsal neuron increase their receptive field such that adjacent neurons becomes responsive to stimuli to which they were previously unresponsive. So the adjacent neurons are becoming responsive. How? By increasing the receptive field area. So this is one more mechanism. And hyperexcitability of flexon reflexes. So the reflexes are being flexon reflexes are being increased in their excitability. So that is one more mechanism of central modulation. And the neurochemical mediators of central modulation or sensitization are substance P, vasoactive intestinal peptide, cholecystokinin, angiotensin, L-glutamate and L-aspartate. So the mechanism of action of these centrally acting neurotransmitters. So these substances trigger changes in the membrane excitability by interacting with G protein coupled receptors which are present on neurons, activating the intracellular second messengers which in turn phosphorylate substrate proteins. So G protein coupled mechanism you already have seen in signal transduction. So that is the mechanism here also. They trigger the changes in excitability. Membrane excitability is being changed by interacting with G protein coupled receptors which are present on neurons and activating the second messengers and then in turn phosphorylating the substrate proteins. A common pathway is an increase in intracellular calcium concentration. So after this mechanism, the final result is increased intracellular calcium concentration. The glutamate and aspartate receptors play an important role in wind-up via activation of NMDA, that is N-methyl D-aspartate, and non-NMDA receptor mechanism. These amino acids are believed to be largely responsible for the induction and maintenance of central sensitization. So see here, this is the primary afferent neuron, A delta and C fibers, so which are synapsing here. These are the interneurons, and the postsynaptic neuron is traveling along the spinal cord. So what is happening in this synapse level we are seeing. So this is central modulation at the spine. So the postsynaptic membrane, we have the NMDA receptors. So when these receptors are activated, they increase calcium conductance and leading to activation of the protein kinase so that the calmodulin is being synthesized, and activation of enzyme nitric oxide synthase leading to nitric oxide synthesis. So that nitric oxide is released into the synapse. These actions also depend on activation of secondary messenger system. So both these prostaglandins and nitric oxide facilitate the release of excitatory amino acids in the spinal cord. So what these are doing, they are increasing actually the pain sensation. So thus the COX inhibitors such as aspartic acid or aspirin and non-steroidal anti-inflammatory drugs also appear to have important analgesic actions in the spinal cord. So because they are decreasing the prostaglandin synthesis and also the substance P. And now we will come to the inhibition, that is at the spinal cord and at the supraspinal. Segmental inhibition is at the level of spinal cord by activation of large afferent fibers. So this segmental inhibition is done by activation of large primary afferent fibers. Wide dynamic range neurons and spinal thalamic tract activity is present in this segmental inhibition. Moreover, activation of noxious stimuli in non-contiguous parts of the body inhibits wide dynamic range neurons at other levels. That is, pain in one part of the body inhibits pain in other parts. These two observations support a gate theory for pain processing in the spinal cord. So by these two observations, gate theory of pain is being accepted, that it is helping in the pain processing or pain modulation at the level of spinal cord. The gate control theory, which was described by Melzack and Wall in 1965, states that substantia gelatinosa, which is present in the lamina 2 and 5, that is the rixed lamina of spinal cord. So in the dorsal horn of spinal cord acts as a gate. So gate means open and close. It allows only one type of impulses to connect with the nerves. So if A beta neurons, we know that we have three types of neurons, A beta, A delta and C fibers. So if one neurons are stimulated, the other two neurons will inhibited. So the SG is activated, which closes the gate to A delta and C. If A delta and C neurons are stimulated, so substantia gelatinosa is blocked, which closes the gate to A beta neurons. So when pain sensation is produced, other afferents, particularly the touch fibers, reach the posterior column of spinal cord, are also activated. So when there is pain sensation, the other afferents, particularly the touch fibers which are present on the skin, reaching the posterior column of spinal cord are also activated. So along with pain sensation, touch sensation is also activated. So these dorsal column fibers send collaterals to the cells of substantia gelatinosa in the dorsal gray horn. So thus impulses ascending via dorsal column fibers pass through the collaterals and reach substantia gelatinosa. Here the impulses inhibit the release of substance P by the pain nerve endings, so that pain sensation is suppressed. So if you remember the previous slide picture, the afferent collateral axons from the pain fiber releasing the substance P. So that substance P is inhibited by the dorsal column fibers. So that is touch sensation carrying fibers. So those are sending signals so that the substance P is released from the collateral axons is being inhibited, so that pain sensation is suppressed. Thus, gating of pain in dorsal gray horn level is similar to presynaptic inhibition. Okay, so in the synapse class, we have seen different types of inhibition: presynaptic, postsynaptic, feed forward. So this is one type of presynaptic inhibition. So how? Before the synapse itself. So that is the synapse of primary afferent neuron with the secondary neuron, that release of substance P from the collateral axon is being inhibited by the other afferent fibers, that is touch sensation carrying dorsal column fibers. So these are the pictures of gate control theory of pain. In the absence of input from C fibers, tonically active inhibitory interneuron suppresses the pain pathway. So if there is no input from the C fiber, the interneuron will be decreasing or inhibiting this pain pathway. And with strong pain sensations, C fiber stops inhibition of the pathway, allowing a strong signal to be sent to brain. So this inhibition will be stopped. So this strong pain sensation can be modulated by simultaneous somatosensory input. So that is touch and other non-painful, that is pressure, crude touch. So their pathways are also activated, dorsal column fibers. So that is A beta fibers. Okay, so the sensation, these nerves are A beta fibers, and C fiber is painful stimulus. Here we can also have A delta. So when these are activated by the A beta fiber, so this inhibitory interneuron is being stimulated so that it can inhibit the release of substance P by the C fiber. Okay, so that the pain stimulus is decreased, so by the activation of A beta fibers. Okay, so in this picture you can see the gate open and the gate closed, substantia gelatinosa. The small nerve fibers are open and they are entering the brain via the spinal cord. And here the large nerve fibers are being in the afferent pathway. So we have seen that A, beta and C fibers. So this C fiber transmission is being stopped by the afferent other pain pathway, that is the dorsal column pathway. So A beta fibers will stimulate the inhibitory interneurons to stop the sensation or the release of substance P from the C fibers. So the introduction of gate control theory has acted as a catalyst for global proliferation of different techniques for pain alleviation or reduction of pain based on afferent stimulation, such as transcutaneous electric nerve stimulation and acupuncture. So basing on this the gate control theory by afferent stimulation, so the naturally body has kept that pain decreasing sensation by activating the afferent touch fiber sensation, touch fibers, activating the touch sensation carrying fibers, dorsal column fibers. So that is taken into uh, various procedures like transcutaneous, electric nerve stimulation and acupuncture. So what these procedures will do, they stimulate the afferent pathways. That is, they stimulate the touch sensation carrying pathway and other pressure sensation carrying pathway, so that the pain will be decreased. So this acupuncture is based upon the pain inhibitory mechanism of enkephalins and endorphins released by this procedure. So you all know that needle sensation. So around the pain area, the needles will be punctured slightly so that the free nerve endings are normally activated because the pain is present. The pain pathway is already activated. So the other sensations, that is touch, pressure and superficial pain, so those are activated so that they will inhibit the substance P release, and also they release the enkephalins and endorphins, that is opioids. So this pain control is brought about by opiate release and inhibition of cyclooxygenase pathway. And this is by tactile sensory signals, inhibition of pain transmission by tactile sensory signals. So touch sensation is being activated by rubbing the skin near painful areas and applying liniments or ointments, often release pain. This is due to stimulation of A beta fibers from the peripheral tactile receptors, depressing the transmission of pain signals. This results from a type of local lateral inhibition. So now we will see the mechanism of action of TENS, that is transcutaneous electric nerve stimulation. The afferent activity set up by transcutaneous electric nerve stimulation inhibits nociceptive transmission in the spinal cord through pre- and post-synaptic inhibitory mechanisms. Not only the spinal cord but also the thalamic regions may be involved. So nociceptive, that is pain transmission, pain pathway in the spinal cord is inhibited by pre and post synaptic inhibitory mechanisms. So the gate control theory is actually a type of presynaptic inhibition. So this TENS also acts post-synaptically, both pre and post-synaptic inhibitory mechanism. It activates the mechanism at both spinal and supraspinal centers. So if we see the supraspinal inhibition, several supraspinal structures send fibers down the spinal cord to inhibit pain in the dorsal horn. So that's why this is called descending pain pathway. So the important site of origin for these pathways include periaqueductal gray reticular formation and nucleus raphe magnus. So these three structures are very important in descending pain pathway. So from these only the fibers are sent down. Stimulation of periaqueductal gray area in the midbrain produces widespread analgesia in humans. Axons from these tracts act presynaptically on primary efferent neurons and postsynaptically on second order neurons or interneurons. So these three are the major structures in the descending pain pathway. So you can see from the brainstem. So this is the first one, periaqueductal gray or periventricular areas. So around the reticular formation, this periaqueductal gray is present, and also the nucleus raphe magnus and nucleus reticularis, paragigantocellularis, all are present here in the pons, and then pain inhibitory complex in the dorsal horn of spinal cord. So from these three structures, the descending pain pathway or the fibers will be sending down to the spinal cord level so that the pain sensation is inhibited. So this is the flowchart of descending analgesia system or descending pain pathway. From the hypothalamus, periventricular nucleus and median fiber bundle, the fibers start, and from the periaqueductal gray and periventricular nuclei along here also the fibers will start and then enter the nucleus raphe magnus and nucleus reticularis, paragigantocellularis, and then finally they enter the spinal cord. In this, the pain inhibiting complex present in the dorsal horn, they will terminate and they will inhibit the release of substance P. So the neurotransmitters involved in this pathway are serotonin and opiates. So all these pathways mediate their antinociceptive or pain reduction action via the alpha-2 adrenergic and serotonergic and opiate receptor mechanisms. So the substances released act on all these receptors, and these inhibit the substance P released from the presynaptic ending. Thus transmission of pain impulses in the pain pathway is inhibited. Okay, so the final result is all the substances released, they inhibit the substance P release from the presynaptic ending, so that the pain pathway or the pain transmission of impulses in the pain pathway is decreased. And in chronic pain, that is the pain which lasts more than 6 months, some patients will have pain for throughout their lifetime. Like if you take the rheumatoid arthritis patients, they have the pain always because of joint swelling, that joint pains will be there. So there is not naturally the body has kept the auto inhibition of pain by these substances, release of these substances and inhibition of substance P from the presynaptic endings. So till now we have seen the different types of modulation at peripherally and the spinal cord level and supraspinal. So now we will see one or two types of other pain modulation systems. So one is cognitive modulation of pain, which involves the patient's ability to relate a painful experience to another event, another pleasurable event like music or anything in which the subject is interested. Example, if a patient in pain concentrates on separate and unrelated images which give him pleasure, like past happy moments, the pictures of happy moments, it is possible to decrease the effects of pain sensation. So psychological modulation, so these things already we experience. Relaxation. Relaxation means systemic relaxation of large muscle groups. So if we relax, if we give relaxation to our body after working hard for a long time or after sitting and studying for a long time, if we relax, automatically the pain will be reduced. And hypnosis, effective analgesic state of inner absorption and focused attention. Reduces pain by distraction, altered pain perception and increased pain threshold. So this hypnosis is a state of analgesic and inner absorption and focused attention. So in this state, the pain will be distracted or altered pain perception. The pain sensation is being altered, and then there will be increased pain threshold. That is, the sensation for pain is being increased. That is, if we give a high threshold intensity, then only the subject experiences the pain. For light touch or light pin prick, the patient will not experience the pain. Another type of modulation is non-pharmacological. So we have seen cognitive, psychological and non-pharmacological. Here massage reduces pain, including release of muscle tension, improved circulation and increased joint mobility and decreased anxiety. So this we all do regularly. Our elders, our parents, grandparents, they do this massage, so which will reduce the pain sensation. And physical modalities like cold and hot temperature. Cold for acute injuries in first 48 hours to decrease bleeding or hematoma formation, edema formation, and also for chronic back pain. And heat works well for relief of muscle ache and abdominal cramping. So neurostimulation is another type of pain modulation which uses a small implanted system to send precisely controlled mild electrical impulses to the nervous system, typically the dorsal horn and spinal cord. The patient feels the neurostimulation as a pleasant tingling sensation known as paresthesias. So this is divided into subcategories based upon the type of nerve that is being stimulated. So the nerve stimulation is being sensed by the patient as pleasant tingling sensation, otherwise called paresthesia, so that the actual pain sensation is being decreased. So two levels we have stimulation, that is at the spinal cord level and also peripheral nervous stimulation. So spinal cord stimulation involves stimulation of dorsal column of spinal cord, that is we are stimulating the dorsal column fibers. So if we stimulate anywhere in the pathway, the specific sensation is being perceived by the person. That is otherwise called law of projection. And peripheral nerve stimulation involves stimulation of specific nerve branch. And out of these two, spinal cord stimulation is the most effective technique for chronic pain management. And then intracerebral stimulation. So it is a method of deep brain stimulation which is used for intractable cancer pain and intractable neuropathic pain. And for nociceptive pain, electrodes are implanted into the periaqueductal and periventricular gray areas. And for neuropathic pain, the electrodes are placed into the specific sensory thalamic nuclei. So directly into the brain areas, that is central areas, the electrodes are implanted so that the pain sensation is being decreased in intractable, that is cancer patients. They always have the pain sensation, and also neuropathic pain, that is pain because of nerve injury. So for these patients there is intracerebral stimulation process. And now coming to the assessment of pain. So when assessing the pain, we have to take the detailed medical history, physical and family history, and some physical examination we have to do. That is the site of pain, any injury, or that only at that site or other sites are also present, like that. Physical examination we have to do, and questioning on the characteristics of pain like onset, duration, location, quality, and severity, intensity, and evaluation of psychological status of the patient. So this is a brief history before the actual management of pain. And pain assessment tools. So how to assess the pain? We have some tools. So pain may be accompanied by physiological signs and symptoms, and there are no reliable objective markers of pain. So it can be assessed by rating scales and multidimensional scale. So we will see the rating scales present for pain. Rating scales provide a simple way to classify the intensity of pain and should be selected based on the patient's ability to communicate. And multidimensional scales help in obtaining information about the pain and impact on quality of life, but are more often time consuming to complete. So the most commonly accepted are the rating scales. So there are various rating scales present, like simple descriptive pain intensity scale, that is with no pain to worst pain, and numerical scale, that is numbering of the intensity of pain is explained by taking numbers from 0 to 10, that is no pain to severe pain. And visual analog scale, that is again no pain to worst pain imaginable. And faces scale, that is depending on the facial expression, that is smiling face to sad face. And verbal rating scale, again that no pain to worst pain. And then pain thermometer, that is expressions and then numbering, and then the verbal, all these are combined in the pain thermometer scale. And coming to the management of pain. So the goals of pain management is to decrease the subjective intensity and to reduce the duration of pain complaints and to decrease the potential for conversion of acute pain to chronic persistent pain syndrome, and to decrease the physiological, psychological and socio-economic sequelae associated with undertreatment of pain, and to minimize the adverse drug effects and disintolerance to pain management therapies, and improving the patient's quality of life and ability to perform activities of daily living. So the main goals are decrease the subjective intensity. The pain sensation has to be decreased so that it does not affect the physiological, psychological and socio-economic sequelae of the patient, and to minimize the adverse drug reaction and disintolerance to pain management, and improving the quality of life. So these are the various approaches: by giving analgesics, anesthetics, and removing or treating the cause; psychotherapeutic approaches, supportive care, inhibition of pain transmission by electric stimulation, acupuncture, etc., and neurological and palliative radiotherapy and pharmacotherapy. So we will see only a few of these different modes of management. Non-pharmacological management involves physiotherapy, psychological and stimulation therapy is palliative care. And surgical procedures for the relief of pain are four types. One is cordotomy, that is in the thoracic region, spinal cord opposite to the site of pain is partially cut to interrupt the anterolateral pathway. Okay, here you can see the needle entering into the spinal cord, so it is cutting some part of spinal cord so that the anterolateral pathway is being interrupted. Thalamotomy, it involves cauterization, that is cauterization or cauterization. The blood vessels are being damaged or specific pain areas in the intrathalamic nuclei in the thalamus, which often relieves suffering type of pain. So in the thalamus, the blood supply is blocked, so that by cauterizing the vessels, the nuclei in the thalamus, we have different nuclei. So the intrathalamic nuclei are often damaged, so that the pain sensation, because finally the pain pathway ends in the thalamus. Okay, so some relief will be there by doing thalamotomy. And sympathectomy, excision of segment of sympathetic nerve on one or more sympathetic ganglia will relieve pain. And rhizotomy is surgical removal of spinal nerve roots for the relief of pain or spastic paralysis. So here in the face, the trigeminal nerve, if we remove the spinal nerve roots, it will cause some relief of pain. So one more surgical process is frontal lobotomy, which involves division of one or more nerve tracts in a lobe of cerebrum, usually the frontal lobe. Okay, so nerve fibers in the brain are cut, often leaving the patient apathetic and shell-like. So this is the final last resort, but not most commonly done. And then pharmacological management. So here we will use the opioids. Opium is a raw extract of poppy plant, Papaver somniferum. So during 19th century, morphine was isolated from opium and its pharmacological effects were characterized. So it is being used in the pain management. So the type of opioid receptors are these: mu, delta, kappa, and characters of these receptors are highly selective for opioids. Mu receptors are highly selective. Delta receptors are mixed agonist and antagonist response are seen, and kappa receptors, opioid analgesics, are selective for these receptors but are not identified. And if you see the mechanism of action of these opioids, so the receptors are present on the primary efferent neurons. So they help in releasing the GABA amino acid neurotransmitter, which will cause again the activation of the inhibition of the descending inhibitory neuron, so that the action potentials are not being sent through the pain pathway. Okay, so this is the mechanism of action of opioid receptors. And non-opioid analgesics are the non-steroidal anti-inflammatory drugs, which are usually considered as non-opioid analgesics. So they relieve pain without interacting with opioid receptors, and they possess anti-inflammatory properties and have antiplatelet activity also, and they do not cause any sedation or sleep, and they are not having that property of addiction, whereas the opiate drugs will have the addiction and tolerance, that is the person wants to take more and more of that drugs. So the mechanism of action of NSAIDs are: the phospholipase A2 will convert the phospholipids to arachidonic acid, and this arachidonic acid is in turn converted to prostaglandins. So this here the conversion of arachidonic acid and prostaglandins is being mediated by cyclooxygenase. So this cyclooxygenase is inhibited by non-steroidal anti-inflammatory drugs. So this is the mechanism of action of non-steroidal anti-inflammatory drugs. So in pharmacological management, we have seen opiate drugs and the NSAIDs, opiate mechanism and non-opiate mechanism. And lastly, the applied aspects. Analgesia means pain. Analgesia means decreased or lost, decreased sensitivity of pain. Hyperalgesia is increased sensitivity to pain stimulus, and allodynia is sensation of pain in response to an innocuous stimulus. And Brown-Sequard syndrome, it is the hemisection of spinal cord. And syringomyelia is loss of pain and temperature with sparing of touch and vibration. So these two will come in the spinal cord transections, lesions of spinal cord. We will see that in a separate class. So these are the few terminologies in applied physiology pain sensation. So abnormal prolonged pain are present in injuries and disease process causing damage to peripheral nerves. Severe debilitating and persistent abnormalities of pain sensation are present. And hyperpathia is threshold for stimulation of pain is increased causing burning pain. So example for this is phantom limb. So absent limb, the limb is actually absent but the person feels the pain in that absent limb. And consalgia is spontaneous burning pain even after the trivial injury. And hyperalgesia is condition in which pain is produced by minor stimuli which normally do not cause pain. That is for touch sensation. If a normal innocuous tactile or thermal stimulus evokes pain, that condition is called allodynia. Okay, so that's all for today's class. Thank you.